you, Martin, for organising this so well and for people for coming. I'm going to talk about antisocial personality disorder. So we're moving from children early this morning through adolescence to adults. And I can't help thinking as an adult psychiatrist, I thought you were supposed to have prevented all this. They seem to slip through in large numbers. So I'm not sure what's happening. But anyway, we fail equally. So, antisocial personality disorder. But before so, we have Martin's book, which I know was advertised yesterday. So this book has been rewritten and came out last week. So this is not the old book, this is a new book, and it's much better. And it's a very popular seller. Okay. Anyway, it's a new practical guide, and it contains antisocial personality disorder, families, and various other systems and so on about mentalizing and personality disorder. And you get a 30% discount if you order it soon. Okay, that's my advertising. Antisocial personality disorder. We've started to become interested in antisocial personality disorder primarily because there were another group of people with personality disorder who were referred into our clinical services and caused a great deal of difficulty for us, for themselves, and other people. And if you look at the characteristics, which I've listed here, which are generally accepted, they do not make for nice reading. And they do not make people actually want to see them, and so on. So when you see people who are deceitful, they don't conform very well, they're impulsive, they're aggressive and threatening, and so on. When they meet health services, not just mental health services, but physical health services, people try to get rid of them. And if you add a little bit of alcohol and a bit of sprinkle of drugs, they definitely do not want to see them. Okay, so it's a big problem. And these people actually get rejected from services. But it is clear that to us that you can formulate them, whether it's correct yet or formulated adequately, we don't know, in terms of mentalizing and difficulties that they have in actually their social cognitive process, their family intimate processes, which is where Karen said it was writ large in this mentalizing process, and certainly also in their own subgroups that they form. So we started to develop a sort of formulation of antisocial personality disorder to translate it into a clinical interventional process, and then to take that onto a research project of actually looking to see if the intervention was of any benefit. So if I can summarize the sort of interpersonal cycle of the person with antisocial personality disorder, we can assume that they are reactive. So they are reactive and they're emotionally reactive. That is apparent to most people. So once they're emotionally activated, whether it's a fearfulness, whether it's an attachment stress, or even another stress, general stress, there's a threat to their stabilization. And as Trudy Russo was just talking about, to an extent there may be a threat to their sense of self, to who I am. I am a person in the world in relation to. And once that threat is set up, of course, there are all sorts of emotional dangers arise. The one that's talked about a lot in antisocial personality disorder is, of course, the affect of anger starts to come out, or at least aggression in some form, and of shame is the other area that is, percolates the literature. What happens is, generally speaking, that individuals with this type of disorder are also known to be high externalizers. So they tend to see the threat out there, and they tend to want to deal with it out there. Okay? They don't deal with it in here, they tend to deal with it out there. So what they do is actually control the threat, and the best way to do that, if it's an interpersonal cycle, is to control the other person in some way. So they engage in rather coercive relationships, whether they're in intimate ones or social ones. And once they do that, they control their internal threat. So all the world is safe at that particular point. And they simply engage in this cycle. So it won't surprise you that should a person with antisocial personality disorder come to see you, they may well start to activate this cycle if you ask them questions about themselves and so on. So they say, why do you ask that? What do you want to know for? Or something like that. They start to push back at you and so on. So you have to have ways in any treatment process of trying to manage those phenomena. Okay, so we can see that there's an interpersonal self-other real problem going on here, perhaps, that is there, just in that descriptive cycle. We also know that mentalizing, when we think about it to try and apply it in relation to personality disorder, is a multifaceted phenomena, and Patrick Leuchten and others have been key in developing these ideas. And there are certain areas that are important that have been mentioned. There's the automatic mentalizing process, there's the more controlled mentalizing process. And we were urged this morning to think a little more about the automatic mentalizing process, which can be so helpful but also very dangerous. And we tend to focus on the controlled mentalizing because we're kind of good at that and we like people to move to controlled mentalizing when they can. But of course in daily life they have to use implicit or automatic mentalizing. They just need to be successful at it and constructive with it in general. And these people find that slightly hard. We also know that there's a dimension of more cognitive areas of mentalizing and capacities and the more emotional areas of mentalizing, which to some extent you can differentiate clinically, and they become important in a mentalizing formulation of someone with antisocial personality disorder. And along with that, we have the problem of self-other, which I've mentioned, but also the focus of mentalizing, whether it's primarily an external focus or an internal focus of self or other. Of course, with antisocial personality disorder, what we tend to get is these ideas that in the end, they are actually tend to be externally focused of mentalizing. They tend to be highly reactive and sensitive to actually facial expressions, which we know, to sounds of voices, and to other externally focused phenomena. And then they tend to make their reactions based on that information. And we finally know that these have neurobiological underpinnings to some extent. So you can map people with personality disorder, and this is particularly antisocial personality disorder, according to these dimensions. So if we take just antisocial, they're other sensitive, but they're also self-sensitive, in fact. And so whether you put 1+ stroke 3 pluses of self-other or 3 pluses self plus so 1+ for other may depend on their affect state. They shift very rapidly. So that box, as it were, is really movable, probably, in various ways. It's a complex situation. But external focus, they certainly are. They're mostly externally focused and are engaged in working out what you want and what you do from your facial expression, your movement, your tone of voice, and these sorts of phenomena. And they're also automatic, immediate. So it's reflexive and doesn't take much scrutiny from their higher level functions. So they're more cognitively organized in general, if they can be, than affective. So these are the sorts of areas that we were working out with people with antisocial personality disorder, and whether or not their pre-mentalizing modes were dominant and under what conditions. So that's what we spent a considerable time discussing with patients, looking at videos and trying to work these things out. But there is evidence in the literature already that people with antisocial problems actually have mentalizing problems. This is an early study from Levinson and Peter Fonagy, and which showed that actually in violent offenders there was a major significant deficit in reflective function, which we've heard about this morning, as opposed to non-violent offenders and so on. So there is. We also know from Svenja Taubner, who's here, that actually to some degree mentalizing looks like it can moderate psychopathic sort of activity or phenomena to some degree. So it's protective in some sense, and without it. So, I mean, I'm slightly joking, but you can be a psychopath and be good mentalizing, you're probably okay, and then you're chairman of Shell or something rather than in prison. But sorry, I shouldn't have mentioned the company, but there's a sort of sense that you can actually manage if you're mentalizing actually moderate some of this effect, is the suggestion. So in the end, you're left with this idea that actually for mentalizing process in people with antisocial personality disorder, there may well be certain cognitive processes which are enhanced. Okay, so these are not just negatives. They're positives in the sense that these things are enhanced, and they seem to have, to some extent, an enhanced ability in their cognitive capacities of mentalizing to recognize other people's mental states. One of the difficulties is they then misuse that ability to exploit or deceive and so on. So that's a major importance for clinical treatment, because they may wish to get things from you as the clinician which actually are mainly self-serving. In various ways. For example, a positive report to the court, or a positive report to the parole board so they can be released from prison and so on. So you never quite know whether your wonderful relationship, which seems to be going very well, is part of a deception or something else and so on. So this is a bit of a problem. We secondly know there are major affective problems. Dysregulated aggression is around, emotional identification is apparent in this group, and a sense of shame is in the literature as being an organizing affective state. And we also, in the literature, are aware there are self-other problems, particularly in relation to empathy for others, which I'm going to talk about, and differentiation of their own internal states. Okay, so that's a brief summary of some mentalizing areas that are important in antisocial personality disorder. Let's just take aggression since it's its core. We know that aggression is an important adaptive interpersonal sort of process and affect, and actually it contributes to survival. So we cannot see it in treatment as being something that should be beaten off and get out of the way for these people in various ways. And that's very, very important. But the problem with inappropriate aggression is it undermines collaboration and creates real troubles for interactions. And we also know that most of the people with antisocial personality disorder have shifted through the system, and they're people who do not desist from aggression. Most people desist over time, and as you know, by 5, 6, 8, 10, they've desisted. But there's a whole group, a subgroup that don't, and they tend to move through the system. And they tend to be the one that have got major mentalizing failures in families in various ways when you consider the family environment, where aggression might become the currency, the interactive sort of currency that affects change in the way that the family processes interact. So that's the first thing. Now, the important for clinical treatment about this, we made it absolutely clear to our clinicians that aggression was not to be seen as a bad thing to be got rid of. Okay, this is not anger management, got rid of sort of phenomenon. Okay, now that's quite important. I'll come back to it. Second thing, we also know self-other problems, and just from a clinical perspective, let alone anything else, if you talk to hundreds of people with antisocial personality disorder, they have fixed perspectives about themselves. They say, I am misunderstood. This is a fact. And you say, well, you know, something like that. They say, no, 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 no. I am, that is what it is. They also have a sense of grandiose self to some degree. They say, you don't know who I am, mate. Huh. And things like this. And when you have a group of them all saying that, this is a bit of a problem. But they have a sense that there is this very powerful sense of their own importance and their demand and their need and their requirements now that infiltrate some of the clinical interaction. They don't have an interest in others. In general, that's part of their definition, and it certainly comes across in various ways. Now, this is important because if they don't really, but when they do, it's self-serving, this is quite important for how you're going to implement a clinical program. And they tend to have rigid representations of what people are or what they're not, based on very limited evidence, and based on automatic mentalizing process usually. And they form hierarchical systems rather than constructive consensual systems. That's going to be important if you're going to have a group, okay? Because they're going to set up a hierarchy of which you're likely to be at the bottom. So that's all right. Okay. And then there's a final area, this empathy, which is a self-other issue to a large extent, as well as an affective issue. And it's important to remember that in empathy, this is a two-way phenomenon. You don't have to understand someone necessarily to be empathic with their state. You don't need to understand the content. You can still do it without that. But generally speaking, the importance of empathy in terms of personality disorder and antisocial personality disorder is that what you've got is a system which is actually creating problems. Because if they have reduced empathic relationship with others, in the normal circumstances, if I empathize with someone who's, let's say, in a state of distress or happiness or whatever, it doesn't matter. If I empathize with them to a large extent, it will constrain me. It feeds back to me and then alters how I am. In antisocial personality disorder, that loop appears to be reduced. So when they see someone who's fearful, it doesn't constrain them. They actually carry on. Okay, so they're not fed back through the effect that things may have, and so on. So they don't do that. And I'm not going to jump to the neurobiology is there in all this, but in antisocial personality disorder. But at the same time, we have this idea that actually, when you look at empathy, it does look like it's reduced. This is an interesting study. But in the emotional empathy, the cognitive empathy seems to be working reasonably well. So they pick up, you are hurt or you are being victimized or something, and they say, oh, it's a bad thing. They can work that out, but actually they don't really care. They're not actually that bothered by it in many ways. And this is a study which shows, you can see down here that actually if the higher PCL you have, it looks like your emotional empathy actually improves a little bit. Now, this is a bit paradoxical to some degree, but it's possible that actually as your psychopathy goes up, you become slightly better at working out people's empathy and so on, and maybe your emotional empathy goes up a bit so you can exploit it even more, but I have no idea whether that's correct. All right. Okay, so there's a whole clinical issue around empathy, which is really important for treatment, is how would we increase the emotional empathy so they are constrained by others, that they do recognize it and so on, and how do we increase their ability to perspective take so they actually are bothered about how someone else sees something and so on. How are we going to do that in terms of clinical practice? And of course, if we're going to do it, they've got to even recognize emotions in others as well as themselves, okay? And emotional recognition, we know, is a problem. Even facial cues, which is the external focus, they have a difficulty in recognizing. My view is that it's a generic, general difficulty. There is a view that it's actually also mainly fear and anger and those sorts of phenomena, but there is a literature which suggests it might be a reduction overall for different levels of emotions. And the same applies for actual other cues. So vocal cues, these are vocal cues in which they fail to recognize many of them. Now, this is going to be a major issue in a group, because if a member of the group says something in a particular affective state, the others may not really recognize it at all. And if they do recognize it, they don't care about it. And if they don't care about it but do recognize it, they then may exploit it. Problem. Okay. And finally, just to mention briefly shame, because I want to jump on about this, I do think shame is very important in the relation to how they experience their own internal states, and it's a massive avoidance system that goes on. Now, this is really important because it's different from guilt, and people try to run groups and various things around guilt sometimes. Social guilt, for example, these are sort of moral emotions. So they try to run groups clinically by saying, well, you know, if you don't come, it affects the whole group. Well, if you say that to a group of people with antisocial personality, they say, well, I don't care. You know, you say, well, you haven't been, you know, and so we couldn't really work through what happened last week with you and John, and then when Patrick came, he said, where are you? And it's affected the whole thing, so that's their problem. Okay, there's no way you can make them turn up by trying to induce guilt. So it's something that we, as it were, try and prohibit, because group therapists like to induce guilt for some reason. I've never understood it, but they do have a certain element of that. So beware of that, because it's likely to be ineffective, and they simply see it as coercive. Okay, so shame is a whole important thing, because shame actually generally is an affect correlates well with actually a sort of threat of social exclusion, and that's really important to people with antisocial personality disorder within their own subgroup. It's important in the wider group, but certainly in their subgroup it is important. And one thing that we do in our groups is actually let them develop a small subgroup, actually. They join up together. All right, so it's very important that shame is monitored. All right, and we also know that generally speaking, there's positive correlations between greater the shame, greater aggression, and so on. And there are studies that suggest if you're a prisoner, as it were, for violent offending, that actually if you score highly on shame, your recidivism rate is much greater than if you don't. Okay, so it's quite a powerful position. So we have a whole therapeutic challenge in terms of the aggression, in terms of the low mentalizing self-other, in terms of the reduction in empathy, in terms of the constraints from empathy and not understanding or being concerned about others, and so on. So there's a major therapeutic challenge of actually, generally speaking, of externalizing any problem that comes along and then becoming coercive when your mentalizing collapses. So this simply says, look, if you start interacting with others and they induce something in you which actually you find problematic, you actually start collapsing in terms of your mentalizing ability, and you tend to then fix your mentalizing at a lower level, and when you do, you become coercive and actually maybe violent. Right, so that's the position. Now, the paradox of this is, to some degree, you want to therefore make sure that you're not inducing a lot of these negative, as you call them, but problematic affect states in these people. So the idea of shame or something like that, or triggering their externalizing processes is a major problem, so you have to be careful. So we reduce what we offer them in terms of individual or group work, so they have group once a week, primarily because we thought the peer grouping might be significant in generating shifts and change, and we also offer them individual once a month only. And there's clear focuses that we've asked the clinicians to work on. And this is where the sort of slight paradox is, that the important issue here is not to solely work on the apparent problematic affect or the apparent problem. So in other words, the aggression, say, or the anger, as it were. You want to try to bolster the absence of balancing emotion. One of the problems is, so that if I'm angry, as you said, something happens, so you feel it, so it is, right? And that's it. You lose any contact with anything else other than that anger, as it were. So you need to balance this to some degree, if you can. So the same applies in the mentalizing system, so that if they're caught up in some way in terms of their affect state, being shame, anger, or something like that. One of the problems is if you focus on that, you get lost in it, and so we try to focus on increasing cognitive coherence around the affect. So you work more on that side of that mentalizing framework, which I'll explain in a minute. We also know you have to spend considerable time with externalizers, which this group of people are, in engaging them in treatment. Externalizers don't stay in psychological treatments in general, okay? And this is what happens. They massively drop out, okay? So it's a major issue. So what do? We engage them, we explain the model, we actually involve people who've been treated in their engagement into the treatment. So there's antisocial personality disorder who sits in the group to keep them in the group, if you see what I mean. Someone who's been treated. So they listen to him. It's all men at the moment. They listen to him more than they listen to us, generally speaking, which is probably right. All right? They are also much more forceful than we would be. We say things like, they're on their mobile phone, the drug dealing phone in one ear, the music phone in another, and the girlfriend's phone in the pocket. And so you're trying to say, look, could you put your phones away or something? And you're saying, well, but you recognize they might need to do this because you're a sympathetic psychotherapist, and in fact, actually, you're saying, well, I see you have to do that in order to be here. Anyway, all this rubbish that we come up with. Well, of course, the expert who's done all this says, do you want to change? Hang on a minute, hang on a moment. What? Do you want to change? I'll ring you back. What? Do you want to change? If you want to change, put those away. Stop it. If not, F off. That's it. Intervention done. I thought, right. Done that. And we've spent 10 minutes worrying about attachment, affect arousal, everything. Okay? So it does help to engage them in these processes. So we identify clear goals with them in relation to, and they're broader than aggression and violence. Everybody focus on their aggression and violence. We're trying to focus on the mentalizing, the loss of mentalizing that results down the line. So we're not that interested in that bottom part. We're interested in the top part when they're functioning to some degree. So we increase their affective understanding. We ask them to identify their own self states. We ask them to identify other states. We ask them to try to do that accurately. We ask them to try to check it out. So, for example, patient stands up in the group and he starts shouting at me, pointing his finger and so on. Where's my Patrick? Embodied mentalizing or something, his whole thing going on. So I say, all right, forget about what you're saying, just describe what your experience is. Okay? No, I said, no, just describe. He describes it. Well, he doesn't describe it, so I say, comes across to me as anger. You seem angry. You raise your voice, you point, you're still shouting, and you've stood up, da-di-da-di-da. Okay, so I describe it. I'm not angry. I said, oh, that's fine. Okay? What's everyone else picked up here? Come on. And you make them say, what are you doing here? I don't know. He comes across as angry. They, of course, said, in this particular group, he's not angry. Oh, that's fascinating. That's seriously fascinating. I said, well, help me, because he's not. So what are you picking up that tells you he's not angry, that I'm definitely not picking up here? I haven't got it. He's just angry to me. I said, Nicholas, sit down. You remember who this is? Yeah. My colleague here, esteemed colleague, who's female in an all-male group, but is treated as a male, because you're not you. Whenever they say anything about females, they say, oh, not you. Sorry. And things like that. But the point here is to try to get them to start working this out in very explicit detail, really, if they can. And you can keep this going for short periods of time, and then it degenerates into a mess and so on, and then you try to get it back. But we're very explicit to try to do that, and this is about affects. And we're also explicit about relational patterns, what relational patterns they set up. They tend to be hierarchical, so it's easier to do it initially between them and the clinicians, right? Because they form a gang, generally speaking, where they all approve of each other straight away, even though, normal people would disapprove completely, okay? But you have to take it from this perspective, and then you can work on that relationship, which is generally hierarchical to some degree. So we try to do that. At the same time, we try to stop them externalizing everything, placing everything out. So we do ask them, say, look, we've got to think about actually what happens in you, not just what happens out there and what you think is going on out there. So we make use of that. And we also try to identify self-serving. It's better when you find it in yourself. So an example would be a patient, we were trying to work on his self-experience just a little bit in the group and so on. And manifestly, he began to find this very difficult. So I deliberately shifted it. I said, well, it looks like Malcolm you don't want to talk anymore. That's what I'm picking up and so on. And we discussed how I picked that up, and other people picked it up, and he said, I don't want to talk about it. So we moved on. Another patient, about 5 minutes later, said, can I just ask, what's the purpose of this group? I said, where's your question coming from? He says, well, aren't we supposed to talk about our feelings and try and push ourselves a bit? Yes, I say, yeah, we are. And he says, well, he hasn't I think we need to push him. Okay, so he says, come on, Malcolm, what were you saying? You were saying, yeah, and then he starts to, and of course, actually he was engaging at that point in a misuse of his capacities. Do you see what I mean? So we could try and get hold of that in the immediacy of this sort of interactional process. So that's an example of trying to do that. So the work is dominated by affective work, interactionally, and self-experience, differentiating it, and also in the relational work, the way they set things up. So I'm going to jump these components. They're key components, though, to focus on for the clinicians. And finally, you always have to pick up the non-mentalizing process that they engage in very, very quickly. So example would be a patient who's being seen just individually, this is, rather than in a group, comes to see me, sits down, he says, don't you turn around and look at me and talk when we walk down the corridor. Okay? So I, of course, sitting down, say, well, what was the problem? He says, just don't do it. Don't ask me about it, don't do it. Very coercive, somewhat threatening. So I decide, because I'm doing MBT, I'll leave that alone slightly. I think he's got an external focus. He's judged some internal state of me, but's created something in him, and so on, that he has to deal with. So I think, well, we can't really talk about it at the moment. So I leave it. I then generate some mentalizing around other areas, and then which is a characteristic MBT maneuver, to see whether I can return to this area of problem from a certain less arousal and more mentalizing. Eventually, 20 minutes in, and say, so what is it that I'm doing? Because I don't want to do it. I just don't want to do it. And he says, I know why you turn around. I said, oh. He said, yeah, what is it? He said, you turn around because you're scared of me. I said, you're absolutely right, but that wasn't why I turned around when we walked down the corridor. That I'm sure of. You're scared of me, aren't you? I said, yeah, to some degree. Okay, you know, because I am, and this needs to be worked out. So we discussed this a little bit, all right? But he's functioning from an external focus, making automatic assumptions very quickly, and then he's controlling. So there's a lot just in that interaction that could be taken apart to say, look, this is a problem. If you think when everyone turns to talk to you, they might be out to, they're scared of you. He says, you think I'm going to hit you over the head? Actually, I didn't think that at the time. I then began worried about it, but, you know. Anyway, so you're trying to engage in this sort of process where you can at least look at what their assumptions are and so on, to try to stimulate further, better mentalizing around interactional process. Okay, so we've set that up as a study. It's a multi-center randomized trial, and people have been trained to deliver the model, and it's set up in probation and in the Criminal Justice Health Service link, and that's currently going on in the UK at the moment. Do we have any evidence it works to some degree rather than trains them up to be better criminals or avoiding the police or various things? To some level, we have a little bit of evidence. Some, I think, was presented in a poster, but we have some evidence that actually their hostility tends to go down to more so in this than control treatment, and also some of their other symptoms, so their paranoia, all of which are very important. That interpersonal sensitivity areas go down, and actually their functioning seems to go up in the antisocial. So we have a bit of sort of understanding that this may be helpful to some degree. Okay, so what I've tried to say is we take a mentalizing sort of view of the problems of antisocial personality disorder, where they are. They're primarily in self-other interaction processes, but focus dominantly around empathy, the constraints of empathy, the ability to be able to do that sort of affect recognition, but of not just of other, but also of themselves. They find identification, this aggressive group that Karin talked about, they seem to come through, they find it very difficult to differentiate affect states. They simply can't do it in themselves, and they don't like doing it either. So we focus on all this, and we focus on the interpersonal, interactional, relational patterns that they set up. And going back to it, one thing that we have also found is important in this, in terms of relational patterns, is a good formulation right at the very beginning of treatment that tells the clinician what's going on. And I'll finish with an episode of a patient who came in, a similar patient, I think you may or may not have been there, and it's a patient you know, came in, I'll be very brief, because came in 10 minutes, 7 minutes before the end, with his earphones in, with his music on, sits down, goes like this. And of course, I'm working with the group the rest of the time, trying to summarize at this point what we've done, because that's what you do. And he sits there listening to his music. I try to bring him in, but he doesn't respond. He says, I've got something to talk about anyway. When you're finished. Okay, so I said, well, and of course, I eventually, through a challenge in MBT, get him to remove these things. I just go, what? Okay, so I think, right, now we've got you, then he says he's got something to talk about it. I say to him, oh, we haven't got time. There's only 3 minutes to the end of the group. Because he goes crazy. He gets aggressive, threatening, angry, quite rightly, as it turns out. Because in his formulation, it says one of your relational problems is that when you have an experience of a need or you ask for something, actually rejection is the thing that triggers off your violence and you become coercive. So he comes in 5 minutes before the end and says, I want to talk about something. And I say, no, finish out. So, of course, he becomes aggressive. Now, I only realized, because my initial reaction was now, something like that. And then, of course, it crept into my mind at last, oh, I've just gone through his relational pattern in the immediacy of the moment. So I apologized to him and said, I'm terribly sorry, sit down. I've just done exactly the thing that we know we're trying to avoid. And I quite accept that I did this, so sit down, what do you want to talk about? It took about 2 minutes because it was all rubbish he wanted to talk about. But, he just wanted to engage in it, okay, to the sense. So the formulation is distinctly important to keep you on track about these patterns that they engage in. Okay, I'm going to stop. Thanks.
Thank you. Thank you very much, Anthony, for this brilliant presentation that gives many insights into technical way of behaving with this difficult how to treat patients. We have some time for some questions.
So what does this patient group want to change about itself, if anything? Is that connected with the shame? What's top of their list?
No, generally speaking, their statement about what they wish to change is that they do want to stop interacting with people in negative ways. They want to improve their relationships very often, they say. They also tend to present and come through when they're depressed. Okay, so they feel miserable, they don't want to keep repeating themselves, and they're recidivist offenders, so they keep bouncing through, and they don't want to keep going back to prison very often. Okay, so they do have some, but their motivation initially is low, and it usually surrounds a report or some comment for probation and so on. Okay, so you have to generate some disquiet in them, if you see what I mean.
Thank you. I may have missed it, but I hope I haven't. You said you wanted to come back to the importance of aggression as an important adaptation. And I'm thinking and I wondered if you could expand on that.
Okay, no, I forgot that. One of the things that you have to try to position yourself as a clinician, which is relatively easy to do. As soon as they arrive, these people, they say, look, if you were in the context that I am in, you would behave like I behave. So I don't want any of this judgment stuff going on. okay? And actually, you have to get yourself into a position to say, yes, you would. It'd be a bit difficult. Example, patient comes in, sits down, he says, oh, he hasn't got much to talk about. We go round, no. Then I said, but you were arrested on Tuesday. Do you think we could talk about what happened? He says, oh, well, that wasn't really very much. I don't know. All right, well, what happened? What happened was that, blah, 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 and then he stabbed someone, tried to stab someone, and he was arrested. So he said, yeah, but anyone would have done it. Okay, in this context, all right? Now, I wouldn't have had a knife necessarily, but, but if I had, I would have done it, according to him, okay? The problem you then got is the rest of the group say, yeah, he had to. Don't you see that he had to do that? And then they start persuading you that this is the only response that is appropriate in this. And to a large extent, you've got to begin to work out, actually, living in that housing estate, with that sort of drug pushing and everything else, maybe I would be utilizing my aggression in a way that, and you have to go from that point of view. Okay? So it's adaptive. Okay? It's not something we got rid of.
Is it connected with some validation of the adaptation of aggression?
Yes. Yeah. They have to extract themselves from the situations, or they have to become resilient to them.
And in some ways, the self-identity as aggressive has to remain part of the core integral self.
Yeah. The self-identity, they cannot be seen to slip down a hierarchy in the system and so on. It's very important.
Question? Patrick?
Anthony, thank you. Marvelous. Very empathic while you were speaking about danger and stuff. But I have a question concerning the facial emotion recognition. You presented in terms of a kind of deficit impairment, and I was actually wondering whether it's perhaps also, as with BPD, slightly a paradox, in the sense that while you were speaking, there were some times, and you played it, some contempt and even disgust in your facial emotional expression and the bodily expression, kind of belittling even. And that's totally understandable, and you act a bit like that. But might they pick up these signals in other people, I'm wondering? So that indeed there's kind of psychic equivalence saying, you look back and that meant that you were not interested in the person, but might that be related to another kind of more subtle indication of that emotion in the interaction with them? And I can imagine there's a range of patients being completely oblivious to these more micro emotions, but I can also imagine that some of them are quite sensitive to all kind of cues, talking about aggression being evolutionary, positive and adaptive, that you pick up aggressive cues or cues of contempt or displays that have to do with competition and rivalry and so on.
Yeah, that's
Quite
absolutely right. They have high levels of sensitivity probably to some micro sort of interactive processes, and they're very quick at picking those things up. Yeah. I wasn't quite sure whether you were saying I was a little bit contemptuous but were they picking that up? Let's say I was in some way.
I'm not saying you are in interaction, but
No.
now you kind of overdo it to say, well, he was going on about these useless crap things.
Yeah.
So, but that's actually something they could pick up
They
in
do.
your voice or
They pick up those things very, very quickly. And they say there's a general reduction, but there's also an oversensitivity in certain areas, which I think is your point, and that's right. Well, no, I think that's probably true. But they do. They, generally speaking, will tell you when you're on the edge, i.e., don't do that. Do you see what I mean? They warn you to some extent. If you're in the position of treater, they have a certain level of code of conduct which we set up at the beginning of the group, which they will adhere to some degree, as best as possible. And they also do see you, generally, if you set it up right, you're actually just trying to help here. Okay, so they usually warn you when you're on the edge. Yeah. Yeah, yeah. They have codes of conduct. They're very good in gang phenomena. Gangs work very well.
Just a brief question. I was very interested, a co-facilitator who's a previous member. How do you find those? What are the selection criteria? I know it's done with substance abuse, and we're interested in doing that with husbands who batter or partners who batter wives. So what do you recommend?
Well, it's a major issue, and many of our centres have resisted it to some degree, but also have accepted it. And I meet with the experts by experience, they're called, every 3 months, and we do. The choice of them is up to the local centre. So, so our role in the main is to try to train them not to be too involved in the group. Yeah, i.e. not to use the group themselves, if you see what I mean. So they're there to, you know, to give advice. Or so for example, it's structured a bit. They will have a little surgery before the group, so that if you're an antisocial and I'm the you can come and talk to me 15 minutes before about this, that, and they give practical advice and so on. And if you say you don't want to come to the group, they'll talk to you about that and things. So, but it's an issue. Well, not really. That's just me seeing them every 3 months, talking with them and getting their views and trying to structure it and so on. Yeah, no, but we should have a training for them, yeah. But you need a training for the clinicians as well.
We have time for just one last question.
I have more of a clinical question, because I was wondering, what would you do with that misuse of mentalization other than you would do with the borderline patients? Because with the borderline patients, I think you would try to get them to mentalize about why they're doing this at this moment, and the effect on others and relations, etc. But like the group one, you just gave an example, and that man that says, hey, we need to push you right now. And you said it was a signal, a sign of misuse of mentalization. But what would you do in this group with that?
Well,
how would you address
don't
that?
forget, this is MBT, it's just for ASPD, so you wouldn't necessarily do anything different with that than you would with a patient with borderline personality disorder who you were trying to work out, well, why is he pushing it or she pushing it? So with him, you just simply say, just hang on a minute. And I actually, at that stage, put myself in. I said, because I thought we'd worked out that Malcolm was a bit sensitive at the moment and wanted to leave it alone. So what makes you want to come back to it? So I get him to start saying, well, he said, well, I thought that was the purpose of this group. I said, yeah, that's the purpose of the group, but what made you suddenly want to come back to it? Do you see what I mean? Try to generate to see if he can say something. He actually picked up, he did admit, he said, well, I'm picking up that he's got trouble with this. Okay, so we could then look at his insensitivity to Malcolm's kind of upset. Yeah. But you're doing the same. You're trying to generate some mentalizing around what I'm doing in relation to and what they're acting, what their position is, and so on.
But then when you get to that point, maybe would he care?
No.
That he's trying to...
No. So you stop him and say, the problem is that you don't care. And we will say to them, say, look, if you go around in life actually taunting people when they clearly want to be left alone, you're not going to have a very good relationship. If our aim is to help you improve your relationships, you're going to have to stop it. You know, sort of. Because yeah. Okay. Yeah. It doesn't do for good relationships, as we all know.
So I would like to thank both Trudy and Anthony for this wonderful session.